بسم الله الرحمن الرحيم. السلام عليكم. أرحب بالدكتورة لبنى المزين، أشكرها على قبول دعوتنا، والدكتورة مشرفة الجلسة العلمية الدكتورة لطيفة الهويش، وأشكر كل من استقطع من وقته هذه الساعة ليشارك الجمعية السعودية لطب أسنان الأطفال هذا اللقاء العلمي. تحياتي ودمتم برعاية الله. دكتورة لطيفة.
شكرا لك دكتورة. Welcome Dr. Libby, and we are honored to have you with us today. And I just wanted to start with announcing the next events for the Saudi Society of Pediatric Dentistry. If you can see my screen, we have an event this Wednesday, 22nd of April at 8 p.m. 2 lectures from Dr. Reem and Dr. Dima Farisi. And also next Wednesday as well, 29th of April, we have another event. So we hope to have you all with us at these two events. And I think you can start, Dr. Lubna. I will stop sharing my screen.
Thank you, and thank you for the warm welcome. I'm really honored to be speaking for you all today and to be sharing some of my knowledge with you and some tips. I know that some of you may have already attended my lecture, some of you may have heard about it, but I've also updated it slightly to be a bit more suitable for specialist pediatric dentists, which I know that most of you are. And I hope that you'll find some benefit from this talk today, and that I can maybe I'll learn something from you as well. So that's the point of today, and also to take our mind off everything that's happening at the moment. So I'm really happy that the Saudi Society of Pediatric Dentistry has been so proactive in organizing these events to keep us all busy, because I know that I'm really missing practicing dentistry at the moment. So today I'm going to talk to you about molar incisor hypomineralization and planned extraction. And of course, it's from a pediatric management perspective. I just completed last year my DClin in pediatric dentistry from the University of Edinburgh here in the United Kingdom. I also hold postgraduate certificates in dental public health and medical education, which is why I'm so interested in teaching and also in advocating good oral health for children in general. So this is where I live, Edinburgh. It's a beautiful city, and after finishing my degree, we decided to stay here because it's the nicest place I've lived in so far. And I've lived in many places. I've lived in Australia, I've lived all over the UK, Dubai, Bahrain, even Saudi Arabia, believe it or not, Riyadh. And if you see on the top right picture, that's one of the streets which is said to have inspired the writer J.K. Rowling's Harry Potter, Diagon Valley, if you read Harry Potter. So it's a really nice city with lots of old buildings, and it's beautiful to walk through. A little bit about me on a personal level. I'm married to Mohammed Al-Muzian. He is an orthodontist, and he's very active in teaching as well. So we make a good team, peds and ortho. And these are our 3 daughters who drive us crazy and make us very happy in equal measures. And I'm a pediatric dentist. You can follow me on Instagram and on Facebook. I'll put these details up at the end. These pages I use more to connect with my patients, but lots of dentists find it useful as well because it gives them some of the resources to speak to their patients about dentistry as well. And on the side, I bake. So when I'm not busy teaching or doing dentistry, looking after my kids, I like to bake, and usually it's creations for them for their birthdays. And this is my Tooth Fairy Tips page, which I hope you'll follow on Facebook. So today's learning outcomes will be, we want to be able to identify the key features of MIH, we want to be familiar with the guidelines for planned extractions, we want to be able to identify cases where these guidelines can be applied in the best interests of the MIH patient, and to familiarize ourselves with the different methods to deliver the options to the patient, and be confident in behavior management for children with MIH. I'm sure you're all really great at behavior management anyway if you're pediatric dentists. And I want you to be able to tailor your treatment plans to fit the individual patient with MIH, because it's all very well me saying you can do ABC, but ABC might not fit the patient that you have. You might need to do X, Y, Z. So that's what we're going to talk about today. And I'm sure you've all seen this meme going around on the internet now. I don't know what dentistry is going to look like after we come out of the coronavirus. We might end up wearing this kind of PPE in the dental clinics. I know that I would be up for it. I don't mind. Today I miss dentistry so much that I extracted my daughter's tooth, but she did beg me to, in my defense. But this is where I'm at right now, missing dentistry. So let's move on to how you're feeling right now. And what I'm going to do is, you can see this duck from 1 to 9, but what I'm going to ask you is, I want to know how confident you are in the diagnosis and treatment of MIH. So I'm going to ask you now, and then I'm going to ask you at the end of the talk as well. So here we go. First thing, how confident do you feel in diagnosing MIH? I'm going to give you a couple of minutes just so that we get more votes in. There's 569 people participating at the moment, so quite a lot of you. Thank you for coming. I appreciate you giving me your time. So we're almost halfway there. Keep voting, everyone. I would hope that you're all quite confident.
The host and panelists cannot vote. So can you give us that option, please?
Sorry? Oh, the
host
okay.
and panelists cannot vote. Can you please give us the option to vote?
Let me see. I don't know if I can do it right this second. I did see the option. I think I'll have to do it for the next poll. So let's end this poll now. And let's see, so over half of you have voted. Let's have a look. So at the moment, most of you are confident. Some are very confident, some are not sure. A few lacking confidence, which is fine. So we're going to build that at the moment. Can you see the results, everyone? Let's see. Can everybody see the results now? Yeah. So let's move on. And let's talk about, we'll do the next poll, which is how confident do you feel in treating? And I'm going to allow, I can see the option now, allow panelists to vote. So if you could vote now and tell me how confident you feel in the treatment of MIH. So diagnosing it is one thing, but actually when you're doing treatment, do you feel confident in the treatment plans that you're providing for patients, carrying out for patients? Because that can be quite a different kettle of fish. So let's see, lots of votes coming in. Excellent. And I would say that when I initially started treating MIH cases, I couldn't understand why we were extracting some teeth. Then when I learned the evidence base around it, I think that's what convinced me and made me feel like when I was planning, I was doing the right thing for my patient, because I had to think about not the tooth, but actually think about the patient as a whole, a patient who's going to grow up and go out in the world. And I wanted to know that when they go out into the wide world, they would I would have done the best thing for them going forward in their lives. So you'll see how that goes as we go through the webinar. So most of you are confident, quite a few are not sure. So I hope that we can change that confidence level and bring everybody up to the top to very confident or confident. So what are the topics that we're going to be talking about today? We're going to be talking about we're going to give an overview of MIH. We're going to talk about the prevalence and etiology. We're going to give an overview of diagnosis, factors that we consider when we're treatment planning, treatment options, restorative materials in MIH, guidelines for planned extractions, and local anesthetic for MIH patients, because there is a little bit of a problem with anesthetizing MIH patients. We're going to talk, after we've gone through all of this, we're going to talk about the tailored approach to treatment, and the behavior management for these patients, and some cases. Now, if you have attended previously, I have increased the cases and they're much more clinical now. So we're going to have some hypothetical patients to look at the end. And I do have a really nice bonus for you all as well. So there's a nice bonus at the end. So overview of MIH. We all know the definition, which is that it's hypomineralization of a systemic origin, and it presents as demarcated qualitative defects of enamel on 1 to 4 first permanent molars, and it's frequently associated with affected incisors. Now, that's been around since 2001. I graduated 2006, and I wasn't aware of MIH. I even feel that my own sister has or had MIH, and I can see that it affected her first permanent molars, and she needed to have restorations in those teeth, and I did the restorations for her, and I was very upset that she needed restorations. I didn't understand why her oral hygiene was so bad that she would need restorations in those teeth, even though our parents were quite well educated and we were brushing well and her diet was good. And so in hindsight, I can tell that she actually had MIH. And we're seeing new patterns emerging, which is that the hypomineralized second primary molar is becoming more apparent. And what that means is that we're seeing children who have the second primary molar is hypomineralized, and that can be indicative of MIH for the permanent dentition. So it's very important that if we see that, we actually keep an eye out and monitor patients as they grow up and get their permanent dentition. So moving on to the prevalence and etiology. Prevalence of MIH is very varied. So in some report it as low as 2%, others report it as high as 40%. So 2 and 40 is a huge, huge difference. And the problem with this is that we do need to know a bit more, and the only way to do that is to have it recorded a bit more. At the moment, we don't have many studies. I think that if we start to actually report it more, we don't know if actually at the moment we're over-diagnosing or if we're under-diagnosing. So is it being missed and misdiagnosed as caries, or is it being over-diagnosed as an excuse for caries? We don't actually know. What I'm happy about is that there's now an index which can help us, because it will standardize diagnosis. It gives us good records when we're making our notes, and we can see how treatment progresses, and this will help us with epidemiological studies in the future. So what is this index? We'll talk about in a moment. The etiology, so we always want to know, how did we get here? When a parent comes in and you tell them that their child has MIH, they want to know why. They don't want why, how did this happen to my child? They might feel guilty, think it's their fault. So it's very important to reassure them. The etiology is not very clear, but what people do know is that it might have a systemic origin, and where the amelogenesis has been disrupted, and this might have been in the early maturation stage or in the late secretory phase. Now, some people think that actually it's lots of factors along with the systemic factors. So what are these other factors? Acute or chronic illnesses, exposure to environmental pollutants, and this is especially in the late pregnancy and first 3 years of the child's life. So what we do is we ask the parent when they come in, you say, did you have any complications during your pregnancy? In the first year of life, was your child sick all the time? So it's important to ask these questions and make a note of them, because this will help us as we go forward and look back on cases retrospectively. It can help us to give a better diagnosis, a better etiology for our diagnosis. But there is the possibility of a genetic role in the etiology of MIH. So what I hope going forward would happen is that we'd have more genetic testing, and genetic testing has become more accessible to people. So I hope it's something that in the future will be done as standard. I'm not going to go through all the causative factors. I'm sure you've all read about them, and they're all in the paper which I have referenced for this presentation. So moving on to diagnosis. How do you diagnose MIH? I hope that you're all quite good at diagnosing MIH. What you're looking for clinically is the white creamy opacities and yellow-brown opacities and post-eruptive enamel breakdown. And so this is basically the spectrum which it presents as. It starts as a very, very subtle white creamy opacity, and then it goes down up to the post-eruptive breakdown, which just looks like a cheesy molar. We say it looks like a cheesy molar which is broken down, and it seems to erupt into the mouth and crumble. And the problem with these teeth is that when they get caries, the caries becomes atypical. And what does that mean? If you look at the top right photo, you can see that caries, how it's spread. And the way it's spread is such that it doesn't follow the fissure pattern and go into the tooth like you would expect. It actually spreads all over the tooth on the smooth surfaces as well, which you would not expect to happen. So that's what we mean by atypical caries. We do expect MIH to affect at least one first permanent molar. It might or might not have incisor involvement. The incisors don't tend to crumble. Sometimes if the defect is near the incisal edge and it's in a traumatic bite, then yes, you might see that area of enamel coming away. So that's something to keep in mind. And what I will say about MIH is the rest of the dentition is not affected. So if you look at the other teeth, the canines, the premolars, the second molar, they are not affected. And so this helps us in looking at differential diagnoses to rule them out. And what are the differential diagnoses? Well, we have fluorosis, and fluorosis is the opposite of MIH, because when you have fluorosis, the teeth are caries resistant. They're very strong, but they're discolored. They have the whitish opacities in comparison to the MIH, which will have the whitish opacities, but will be caries prone. So it's more likely to get caries because it's weak. And we don't usually see fluorosis here in Scotland because we don't have fluoride in the water. You would have to ask your patient when you're taking your thorough medical history just to see if they have fluoridated water. They might be drinking a bottled water which has fluoride in it. So that's something that you need to keep in mind. And looking at things like fluorosis, they will possibly affect all the teeth, whereas MIH will only affect the first permanent molars and the incisors. If we're looking at enamel hyperplasia, so enamel hyperplasia is quite difficult to differentiate between MIH and enamel hyperplasia, and sometimes it really doesn't matter which diagnosis you're giving. So I wouldn't be too offended if somebody said it was enamel hyperplasia when in fact it was MIH. It's not really going to change my treatment plan. When we look at amelogenesis imperfecta, it's going to affect all the teeth. So if we think it's amelogenesis imperfecta, we would wait for the rest of the permanent dentition to erupt, and then it would become apparent if the other teeth were affected. It would more likely be amelogenesis imperfecta than MIH. Another way to check for that is to look at the palatal surfaces of the incisors, because MIH only seems to affect the labial surface of the incisors. If you were to see demarcations on the palatal side, it might lead you to believe that it wasn't MIH, and it might in fact be a different anomaly such as amelogenesis imperfecta. Then by taking a thorough history, you would be able to either diagnose it as white spot lesion or rule it out as a white spot lesion, and the same for traumatic hypomineralization. So white spot lesion would probably tie in with bad oral hygiene, and it would probably affect the erupted teeth. So even the primary teeth that were there would probably be affected by white spot lesions. And traumatic hypomineralization, obviously you'd have a history of trauma, although not all histories that you take from patients are reliable, but this is something to keep in mind. Now, the last thing which might help you with diagnosis of MIH is that sometimes, very rarely though, we have eruption difficulties due to the enamel roughness of the six. It doesn't seem to be able to erupt as it usually would into the oral cavity. So when we're looking at severity, I'm not going to go through this in detail, but I've just summarized the severities into a table, and all it encompasses is whether or not there's opacities, post-eruptive breakdown, caries, hypersensitivity, or incisor involvement. Now, mild and moderate and severe is how it's staged, but this is quite difficult because it's very objective. What I see as moderate, maybe you will see as mild. What you see as severe, I might see as moderate. So it's very vague, and it's not a very good way of making a good, accurate record for your patient. Whereas now we have the MIH treatment need index, which is much more thorough, it's much more specific, and I think that this is the tool that we need to be using as standard for all our MIH patients. It's something that maybe you can have down in your clinic to refer to until you know it off by heart, and that way you can make a note on the patient's file exactly where they're at with their MIH treatment needs, and this will help other clinicians when they are managing the patient with you. So I would highly recommend that we all start using that. Now, recently they did some research to see who should be treating MIH. So every dental health system is different. In the UK, we have general dental practitioners, and they see families as a whole, so from children through to adults. And if they have any difficulty in treating any of those patients, they can refer to secondary and tertiary centers for specialist involvement. So they asked the attitudes of the general dental practitioners and specialists in pediatric dentistry to see who they thought should be treating MIH. And what they found is that specialists felt that compromised first permanent molars should be referred to a pediatric specialist, and the GDPs felt that they should be treating these children. So there was a difference of opinion. And what about when they were treating? Was there a difference in the type of treatment they were providing for these children? Yes, there was. So the GDPs seem to be doing more restorations, including RCTs for their compromised first permanent molars, whereas specialists seem to go more towards extractions. So that's something interesting to note, that the specialists were in the UK tend to have a preference for extractions. And I think as we go through the presentation, you'll see why that is. And let's talk about what MIH means to the patient. So when the patient comes into you and you tell them that their child has MIH, I think the first feeling that the parents have is guilt. And that's because they feel like it's something that is within their control, because they're educated to think that their children, if they brush their teeth and give them a good diet, they won't get holes in their teeth. And when you tell them that their child has a hole in their teeth, this might lead them to feel that actually I'm doing something wrong for my child and it's my fault. So it's really important to reassure these patients and their parents that actually they're not doing anything wrong. This is something out of their control. It's something that you are born with. It's not something that you have caused for your child. And what it means to the, I'm sorry, my computer is skipping ahead of me, but what it means to the patient is the patient will have pain, and they'll have a post-eruptive breakdown. They might have pulpal involvement. Their teeth will be sensitive, and this sensitivity can mean that they won't brush these teeth very well. They won't allow their parents to brush the back tooth because it feels sensitive to the cold water when they're brushing, and this deterioration in oral hygiene leads to an increased caries risk again. So they're stuck in a very vicious cycle of not cleaning because it's hurting, and then that causing poor oral hygiene, causing caries, and then they're becoming pulpal involvement, which is even more painful. So, and the other issue is that the caries progresses very rapidly for them. So even the smallest, the beginning of caries will spread quite quickly over the course of a month or two. So it's very important to be monitoring these patients carefully. And this can lead to anxiety. So all of these factors, which I said, like pain, and the sensitivity, can cause anxiety in a child because they won't want you to come near them when they have a tooth which is bothering them. And it also gives a very big treatment burden to the parents and the child because all of a sudden they've gone from having to see the dentist every 6 months and everything is fine to seeing the dentist and maybe having to talk about multiple appointments for restoration and stabilization of their teeth, appointments for orthodontic assessments, appointments for possible extractions. And talking to them about losing teeth is also quite worrisome for them. And all of these appointments can mean that they're missing school. They could be missing school anyway due to pain, or they might be missing school because they have because they are attending appointments or they're in pain. So then we come over to the aesthetic concerns with the anterior teeth. So anterior teeth, because they have these opacities, it can lead to them being bullied, and this is quite it's quite a problem for children, because I'm sure you know that in schools, children will pick on anything. So if they find that that child has the yellowish brown demarcations on their anterior teeth, this could lead to them being bullied, and that can be quite a significant effect on the mental health of that child. And I'm not sure how the healthcare system works in all over the Middle East, but in the UK, children are covered for dental care until the age of 18. After that, they have to pay for themselves. And so this can be a financial concern for some families in different parts of the world, where they actually have to pay for the dental treatments which you are planning. So that's something that you have to keep in mind when you're seeing the patient. For you as a clinician, what does it mean? It means that local anesthesia can be difficult. You're dealing with a patient who has fear and anxiety, we said, because of the pain and the sensitivity that they have. They probably have no past dental history. If they've never had dental treatment before, this can actually be a burden on you, because you're getting this child at a very difficult age. So between the ages of 6 to 11, 12, they're quite difficult to handle in terms of behavior management. And like I said, they have pain and sensitivity, which is difficult to manage. They'll need multiple assessment and treatment appointments. They'll possibly need, for example, a root canal treatment. If they need a root canal treatment, that's a long appointment. And so that can be stressful for you as a clinician, trying to distract and manage this child for a long period of time. And the restorations in MIH patients are not as straightforward, because the bonding can be compromised. So these are all the factors which will impact you as a clinician when you're treating MIH. So when a patient comes to my clinic and I say that they have MIH, or I think that they have MIH, this is the leaflet which I give them, and it's a very nice leaflet. You can access it online. It's available for free from Guy's and St. Thomas NHS Foundation, and it gives a very nice, concise overview of what MIH is, what it looks like, why have they got it, do we need any tests, what are the treatments going forward. So it's a really good leaflet to have in your clinic to give out to patients, because what can happen is you give them lots of information, they're bombarded by all this information, and then when they leave, they've forgotten half of it, and that makes them worried. So when you're giving them information, you're giving them the power and helping to alleviate their worries as a parent. And also, if one parent has attended and the other one hasn't, that means that they can relay the information correctly to the other parent of the child, which is very important as well. So going back to our topics, we're now moving over to the factors which we need to consider when we're treatment planning. So when we're treatment planning, we're going to look at the child's age, because that can have an effect on their behavior management. And also, when we talk about age, I mean dental age and chronological age. So dental age, we need to take into account how close they are to their sevens erupting, which is an important factor we're going to discuss in planned extractions. We need to look at the severity of the MIH. Mildly affected MIH patients on the lower end of the scale, we won't need to do as much for them in terms of restoration and extraction, but we might need to do more in terms of enhanced prevention and sealants. So that's something to keep in mind. We also have to look if there's pulpal involvement, because that will affect our treatment plan. We also need to see if the third molar is present. We need to assess the restorability of those teeth which are involved. So if we have one of the teeth which is severely affected, we need to see if actually in the long term, is it restorable, or are we just doing heroics for a tooth which cannot be restored in the long term. And when we're looking at that long-term prognosis, we also have to factor in the long-term treatment cost, because there's no point in you giving a family with low socioeconomic status signing them up for a restoration cycle, which the child will get for free until they are an adult. And then once they go over into adulthood, they're then burdened with this cost, which they cannot afford. So that's something that you need to bear in mind when you're treating your patients. And we're going to talk about balancing and compensating extractions as well, because this is something which is in the guidelines for extractions, and also hypodontia. So hypodontia is an important factor, because if you have an affected tooth in a quadrant where you also have hypodontia, that will change your treatment plan. So the tooth that you were maybe uncertain about extracting or restoring might become more reasonable for you to restore it, because you are mindful that they are missing teeth in that arch. And at the moment, so especially the missing fives, so if you have a missing five in that quadrant, which is planned for extraction, in the quadrant where you have the six which is affected, it's important to look for the hypodontia. I'm currently just polishing up my systematic review about missing teeth, about hypodontia, and they're linked to malignant disease. And this has a lot of, we're talking about genetic testing for that. So I think that genetic testing is something that should be utilized more in the dental field, for us to be able to identify these factors and see if they have links to other things as well. So I think it would be quite useful. That's my paper, which will be coming out this year, hopefully. And the other issue is, if you have missing fives, this can mean that you have infraoccluded primary molars in their place, and you need to be able to manage that as well. So I had a nice review that I wrote about treatment planning for infraoccluded primary molars. I will share the link for you to access that as well. It's quite a comprehensive guide. So what are the treatment goals? When I have a patient, my goal is to do as little as possible, not because I'm lazy, but because I want to minimize their treatment burden. I don't want that child to go through a lot of treatment, and it is tiresome for the patient, it's tiresome for the parents, and it's tiresome for you as a pediatric dentist doing all the management for that child as well. So the primary goal is to minimize treatment burden. How do we do this? We do this through enhanced prevention. So we're going to really go at them with the prevention tactics, and we're going to go for remineralization treatments, and we're going to manage their sensitivity, because if we can do this, it can help the child a lot. So now we're going to move on to our treatment options. I'm not going to spend too much time on this because you're all quite familiar with these things. I'm just going to read through them so we can focus more on cases. So we would seal a tooth, we can temporize a tooth, we can restore the tooth, put a stainless steel crown on, or extract. So this is how it kind of progresses through treatment. You'd start with the simplest, which is sealing, and in this case, I'm referring to the affected molars. So I refer to the SDCEP guideline, which is the Scottish Dental Clinical Excellence Programme. It's a fantastic guide. I'll show you it, and you can download it for free, and it gives you a very comprehensive guide with lots of pictures and lots of information. It's all evidence-based information, which is great to have. When you have mildly affected first permanent molars, the first line of action is to put fissure sealant on, and to make sure that you're getting fluoride on that tooth as well, to remineralize it, decrease hypersensitivity, and strengthen that tooth, hopefully. So that's the first line of action for these children. And when you're doing fissure sealants, I tell children that it's like getting gel nails, but for your teeth. I'm really happy that at the moment in my clinic, I have some nice sparkly, I have some nice sparkly, sorry, I think I've been on my computer for too long today. It's trying to lock me out. So I have some nice sparkly shades as well, glittery ones. Here I've got a Fuji pink on a tooth as a fissure sealant, which is good because you can see it. And this is a white shade of fissure sealant. So it's good to have shades because then you can see it a bit more clearly. What I give children when they come to see me at the clinic is a social story. I know that it's meant to be used for autistic children, but I find it really effective for all children because children like to know what is happening. When they know what is happening, they are much more likely to cooperate. They are much more likely to accept the treatment much quicker. So this shows all the instruments that we're going to use. I have given them really nice, cute names because I wrote this social story through an app, and I can tailor this social story to suit whichever patient I want to. If I want to drive a message home to that patient who doesn't like water in their mouth, but also doesn't like taste, I can explain to them that I will keep their tooth dry if they keep their mouth open. So it's a way of getting their cooperation and showing them all the steps. I send it to the patients after we've had our initial assessment appointment. This is what we're going to do next time. The parents read through it at home with the child, and that just helps the child to cooperate better with their treatment. So I'm just going to check that everybody can still... Hi, everyone. I don't know where I lost you or if I lost you. Can anybody hear me?
Yes, Dr. Libby.
Oh,
Yes.
sorry. Did you hear that last bit?
Yes.
Yeah. Okay. So you can hear me. Excellent. Sorry. I think with the coronavirus, we're spending so much time on our computers that our computers have reached the point where they're locking us out and giving us limits. So I know I've put time limits on my children's iPads and phones, but it seems that that Zoom has also put, not just Zoom, PowerPoint and everything is putting time limits.
It's being overused these days.
Overused, yes, exactly. Okay, so let's go back to our presentation. Okay, so this is the social stories are what I use for all children, and it's I tailor them to each child, and I email them to parents the day before, sorry, not the day before, the day of the assessment appointment, so they can go home and read them, and they'll read them before they come to the appointment multiple times. That way the patient knows exactly what to expect. I can just give them a quick summary at the beginning of the appointment, and they will continue. So this is the app that I used to create that story. It's not expensive. I think it was £15, which is around $20 or something. And you just pay one time, and then you can add your own audio, you can add your own images, you can add your own writing. And I send it as a PDF to my patients. And you can also make it specific to the patient themselves. You can actually use their own photos as well. So moving on to toothpaste, here in the UK, we recommend that you use a fluoridated toothpaste under 3 years, 1,000 parts per million, and over 3 years, 1,450 parts per million. And we would use a smear for under 3 years and a pea-sized amount for over 3 years. So that's again going back to the SDSEP guidelines, and you can check your fluoridation levels for your children and what they're having before you give them advice about fluoride toothpaste. The other mode of fluoridation we give to our patients, especially MIH patients, is topical fluoride, and that's 22,600 parts per million. I like to give them a choice of flavors because that makes the child feel a little bit in control. So instead of saying to them, would you like to have some fluoride on your teeth? Is that okay? I will say to them, we're going to paint some fluoride on your teeth today. How lucky are you? Which flavor would you like? And I give them a choice of flavor, and I think that gives them the feeling of control, and that can help with their cooperation in the treatment. So what we need to decide is this child a low risk or high risk? If they had mildly affected teeth, I would put them in the lower risk category. If they had more severely affected, I would go in the higher risk category. If they're low risk, I'm going to give them fluoride every 6 months. This is the topical fluoride in addition to the fluoride that they're using for brushing. And if they were higher risk, I would see them every 3 months to apply this fluoride. And always make sure that you use some floss to make sure that you're getting that fluoride into the contact points between the teeth as well. That's really important. So we're up to restorative materials. So this is the SDSEP guideline. You can download it online. It's free. It's a great guide for everybody. And anybody who asks you on treating children, just direct them to this manual. The materials we use in MIH are GICs, composites, stainless steel crowns. Now there's ICON, which is a newer thing, which I have trained to use, which is very good. But looking at what our treatment goal is, we want to seal. So sealing is the most important aspect. If you can get a seal on the tooth, it's going to decrease the hypersensitivity and it's going to decrease the caries rate in that tooth. So recently they did the FICTION trial in the UK, and they looked at, they did an RCT, and they had 3 groups of people with preventive measures and conventional restorative measures. And what they found was just doing prevention can be just as good as doing proper, well, not proper, but doing conventional restorative treatments for children, which is reassuring, because I think that doing less for children and knowing it's still going to give them a good outcome is a bit reassuring for you as pediatric dentists when you have low cooperation. So if we look here, there's even glass ionomer cement, which we use in the pink color. It's called Fuji Triage. This is very good when you have a partially erupted molar and you want to put on a sealant onto that tooth before it erupts totally, and you, at that point, you won't have very good moisture control, and you might not even have a very cooperative child. So being able to do this finger press restoration just to seal the top of that tooth can be very beneficial, because it's also going to leach some fluoride into the surface of that tooth and strengthen it. And we'll talk about how that can help with anesthetizing later on, and also it can help the child to acclimatize as well. So fissure sealing over a slightly cavitated tooth is very acceptable, because you are sealing in that defect, you're sealing in the caries, and it will give you a good outcome. But obviously you need to check that you are that the margins of that sealant are robust every time that they come in. And the whole technique is fantastic for sealing in teeth to make sure that any caries doesn't progress. And also if you have very high sensitivity, so very hypersensitive tooth in MIH, it might be an idea to put a crown on it to help that child to overcome that sensitivity if sealants aren't working. So you can also use it as a temporary restoration. So if you do have a cavity and you can do some stepwise removal of caries and add in some glass ionomer in the intervening times when you're waiting as an interim restoration before you put in the final restoration. And these are the preformed metal crowns that you can use on 6s. Here is placed on a 6. This radiograph shows it in a case of dentinogenesis imperfecta, where they placed it on all 4 6s. It can happen in MIH as well, that you would place it on all 4 6s. And the reason being is you might need to temporize it until the time that you want to extract those teeth. But also you might want to decrease the sensitivity for that child as well. And they come from various companies. You have to trim them because the gingival height of the tooth is quite small in children, whereas these crowns are probably designed for adults because they're for permanent molars. So just trimming them so that the gingival height is less will help you to be able to fit them. So what you need to do is find a size which is too small to go over the bulbosity of the tooth, and then trim it with some scissors, and that will enable you to see it correctly over the tooth. Now, ICON is something quite new, and at the moment it's used with lots of success for the anterior teeth. So this is one of the treatments that you can recommend to your children who are coming in with MIH opacities on their incisors, because that's reassurance to them that you can actually help them to get rid of these white spots. And Dr. Jeanette McLean, who works in the USA, I think, she is she uses the ICON a lot, and she actually puts up lots of pictures, which I'm very grateful for. The other use of it is for interproximal caries. And that can also help, what we're hearing actually is that it can also help with MIH affected teeth, posterior teeth, so the first permanent molars. And they're saying that if you put it on first permanent molar, it can help with the bond strength of subsequent restorations. If you were then needing to restore that tooth, you would be able to restore it with better bond strength if you use Icon before you do the restoration. Now, moving on to the anterior teeth, first line of treatment for the anterior teeth is reassurance. What do I mean by reassurance? I mean that you need to reassure the patient and their parents that it's absolutely fine for them to have these white opacities on their teeth, because what they'll hear from friends, and I say friends the term loosely because they're probably bullies, but they'll be telling them, you know, why are your teeth like that? Why are your teeth so yellow? Because the rest of the tooth will appear quite yellow in comparison to the white spot. Like I said earlier, if the spot on the teeth is a bit brownish in color, this can mean people will be asking them, you know, why don't you brush your teeth? Why do you have brown marks on your teeth? And so it can be quite damaging to the child's mental health when they're being bullied about these things. And so what I say to patients is, I don't tell them I can make your tooth look normal. I will say to them, I can make it look less boring, because I don't want them to feel that what they have is abnormal. I always refer to it as a freckle. So like the freckles that you have on your face, I say this is a freckle, but it's on your tooth. And, you know, you can't blame people for having freckles. It's exactly the same thing for having these opacities on your teeth. But when would we intervene for these children? We try not to intervene until the threes are erupted, and there's a few reasons for that. The threes are always darker than the centrals anyway, and laterals, and so we want to be able to treat the 3 to 3 as a whole so that we get a good result for the child, and we don't want to, for example, bleach the centrals and laterals, and then the canines will appear even darker in comparison to those lighter teeth. So we want to wait for those teeth to come through before we intervene. And also, we don't want to enter the child into the restoration cycle too early. By getting them into the restoration cycle too early, it's a lot of treatment burden, it's a lot of financial cost as well. So what we would start with is the least invasive procedure, which is bleaching. And bleaching just works by lightening up the rest of the tooth so that in comparison, that white spot will fade in comparison to that. The next step would be microabrasion. So especially in the brownish discoloration, or if it's got some roughness, microabrasion can help with that. And then we move on to Icon. Icon is showing fantastic results for these white spot lesions. And then if none of these worked or didn't work as well as we wanted, weren't giving us the result we wanted, we could move on to direct composite veneers. Of course, not cutting away any tooth structure. It's really important that with our pediatric patients, we're not cutting away tooth structure. We want to save that tooth structure for when they're older and they can have more definitive restorations. And the thing with parents nowadays and children is they will come in and they've heard of these Hollywood smiles, they want veneers. Veneers are going to fix everything for them. You need to make them understand that you can't have veneers for children because the gingival line will change as they grow older. And we don't want to put a veneer on and cut away tooth structure for them to then need to have that replaced as their gingival line changes. So that's really important. So we need to save those treatments like veneers and crowns until they're in adulthood. So now we're going to move on to the second part of the lecture, which is the guideline for the planned extractions. And the Royal College guidelines are the ones that I've put. There's all two papers, which are quite a bit more recent. So one of them is the lower first permanent molars developing better predictors of spontaneous space closure, which highlights the need to look at the bifurcation of the 7s for calcification, but also to look at signs in the 5 as well. And then the nicest paper I've seen recently in 2019 is interceptive extractions for first permanent molars, a clinical protocol, and it has this fantastic flow chart on the right here that you can see, and it just asks you a very simple question: what is the long-term prognosis of the first permanent molar? You will either know it's good or poor, or you'll be uncertain. So it's these uncertain ones that this flow chart is very useful for. And there is an ideal timing for the first permanent molar extraction. And what is this ideal timing? In the maxillary arch, you seem to get good results no matter what the timing of extraction, so early or late, or on time. However, in the mandibular arch, it seems to be more time sensitive, and you get variable results. Now, the reason why you would get variable results in the mandibular arch is because the type of bone which we're expecting the tooth to move through is different. So if you compare, the density of the bone in the mandible is quite different to the cortical bone in the maxillary arch. So that's why it's very important that we get the timing right specifically for the lower molars. And we're looking at a range of 8 to 10 years. Some children are early and some children are late. It really depends on their dental age. So we're looking at a clinical sign of eruption of the laterals, but the 7s and 5s shouldn't be erupted. And radiographically, you should see that the 7 is still within bone. It shouldn't be out of the bone coronally, and the bifurcation should have signs of calcification just starting. And why is timing a problem? It can only really be a problem in the mandible, like I said. If we delay the extraction in the mandible, what happens is we get mesial tipping and rotation of the 7s. So they tip mesially into the space of the 6 rather than drifting to take the space of the 6 and close the space. And also the 5s can tip distally as well. So we get mesial tipping of the 7 and distal tipping of the 5, which leaves a quite difficult space to restore and clean. And that space is an issue for that patient. But if we go too early, so if we extract from the mandible too early, we will not know if the 8s are present or not, because radiographically we won't be able to see. And the mandibular 5s can drift distally through the bone and maybe not erupt in a favorable position. And the labial segments have been shown to retrocline and increase the overbite for that patient. That's why we need to get the timing right for the mandible. So what are the guidelines for the first permanent molar extraction? They've split it up into class 1 cases, class 2 cases, and class 3 cases. Now, for class 1 cases, we'll talk about minimal and moderate crowding. For class 2 cases, minimal and minimal crowding and crowding. And then class 3 cases, I've put this meme or this GIF because it's complicated. So it's very complicated in class 3 cases, and we'll talk more about that in a minute. So if we have a class 1 case, so a child comes to you, they have class 1 minimal crowding. When should you extract their first permanent molars? If that is what you have decided your treatment plan for that tooth is, you should extract at the optimal time, which is when the calcification of the bifurcation of the 7 is visible radiographically. You do not need to balance the unilateral first permanent molar. So if you're extracting one, you don't need to extract the same tooth in the same arch on the other side. If you're extracting the mandibular, they do say to compensate with the maxillary above it. However, if you are able to give the child an appliance to keep that maxillary first permanent molar in place, then that is also an option to stop it from over erupting. Or if you're able to monitor it and then make a decision, that's also an option. If you're extracting the maxillary first permanent molar, you do not need to compensate by taking out the mandibular first permanent molar, because it will not over erupt just due to gravity, I guess. Then if we said that we had moderate crowding, again, we would wait for the optimal time. And if we have bilateral crowding, we would balance that extraction and consider compensation with maxillary first permanent molar. And if we had labial crowding, we would consider delaying extractions until the second permanent molar was erupted, because that would enable us to use the space for alignment. Or you could just do the extraction at the optimal time and then deal with whatever crowding appears in the permanent dentition. So the class 2 cases with minimal crowding, with the mandibular first permanent molar, we want to extract at the optimal time. But with the maxillary, we want to give the orthodontist the gift of space. This is what I say to my husband, who's orthodontist. We work in the same clinic, so we work together on various cases when it involves children. And so I like to give him the gift of space. If a maxillary first permanent molar needs to be extracted for an MIH patient, I would be looking to temporize it and keep it in place for as long as possible after that window of opportunity for optimal extraction is gone, so that the orthodontist can use that space to correct the malocclusion in the upper arch, and that will avoid you having to take out another healthy tooth. So you're taking out a tooth which has a compromised prognosis. That is better than taking out that tooth and then later having to extract a healthy premolar as well to correct the incisor relationship. So that's what you need to do. You need to try and give your orthodontist the gift of space in a class 2 case. Remember that. And if you're extracting mandibular and maxillary at the optimal time, then you'll need to address the crowding in the permanent dentition when it comes through without giving the gift of space. So if they do have crowding, so that one was for mild crowding. If we do have crowding and for the mandibular first permanent molars, if the 8s are present, we will extract at the optimal time, or we'll extract the mandibular maxillary at the optimal time and immediately use a fixed orthodontic appliance. So that's another option. So that's something you would have to discuss with the orthodontist who would be taking on the case. And you do not need to balance and compensate mandibular first permanent molars when you're doing when it's a class 2 malocclusion for that child. And class 3, never touch it. Go straight to your orthodontist. This is my favorite orthodontist, my husband. I won't say he's the best because that would be biased, but he is the best. So here we are. Where are we up to? We've looked at so many things, and now we're going to look at the issues with local anesthetic for MIH patients. And this is something that lots of dentists struggle with because they know that something is different about these patients. The problem is that they have a hyperemic pulp. Their pulp is overstimulated, and you want to get good anesthesia for these patients if you're planning on doing a restoration, because you can't get a good quality restoration without good anesthesia, and that will lead to good cooperation. So the insulation of these pulps is poor. What can help is inhalation sedation because it has a relative analgesic effect. And when you're doing your local anesthetic for these pulps, using intraligamental, intraosseous, and palatal anesthesia can help. Using infiltration with articaine in addition to a livular nerve block can help as well. Using rubber dam isolation can help because sometimes the tooth that you're actually working on is anesthetized, but what's happening is that the air from the turbine and the water spray from the turbine is going on to the other teeth in the oral cavity, and those are sensitive, and that's what's causing your patient to have pain and discomfort. So that's something to keep in mind. And you could try even using the slow saliva ejector rather than the high volume suction, because again, that cold air coming over the tooth can stimulate the sensations and make it really uncomfortable for the patient. So pre-operatively, you can also do something, which is to give the child toothpaste to use before they come for their restorative appointment. So you can give them a desensitizing toothpaste, a toothpaste that is specifically for sensitive teeth, or you could apply fluoride varnish for them at one of the pre-restorative appointments, and that can help give a sedative effect for the pulp and kind of make it a bit less sensitive, and that can help with numbing up as well. And putting a sedative in-term restoration is another option, which is where you don't excavate any caries, just put in a GIC filling, and that GIC filling will leach fluoride out into the tooth and also give it a sedative effect and make your anesthesia more profound in the next appointment. If none of this works and that patient, you just can't get them numb, you can't anesthetize this tooth, it's going to be difficult to do a restoration. You might need to even think about the last resort, which is a GA for this patient for treatment, or to abandon restoration and move on to extractions. When I'm giving children local anesthetic, I've put this nice picture of a hedgehog because that's the story that I tell my children. It's very important to distract them when you're giving them local anesthetic. So I do this regardless of whether they are having inhalation sedation or not. So they could just be on chair and I'm giving them local anesthetic. I will tell them this story. I give them first I give them the topical anesthetic, which doesn't taste very nice. So I talk them through a story where I say, this is hedgehog flavored. And I use, every evening I collect all the hedgehogs in my garden and I give them a bath. And then I use the bath water and I sieve out all the spikes from the hedgehog so you don't get spiked from it. And I make sure that I boil it up so that the flavor is really nice and strong. Can you taste it? Doesn't it taste amazing? And the children will look at me like I'm very crazy, which I probably am. And they will be totally distracted. And then I'll say to them, oh, if you don't like the taste, I'll just wash it away. And the nurse will hoover it up so that you don't have to taste it. All of these things are distracting them. The sound of the suction, the water spray, they're expecting something cold. So they expect the local anesthetic as it's being administered so they don't get a fright. And just talking them, distracting them and talking to them saying it's going to feel really cold because this water is really cold, we didn't warm it up, but if you think really nice warm thoughts then you will help to warm it up and it's going to feel like a big warm balloon. So that's the way that I introduce local anesthetic to children. Another thing, which is a tip from me, is to use use the topical anesthetic in the appointment before you're going to give local anesthetic. So putting the topical on the child's tongue or on their gums, their lip, in an appointment before they have to have local anesthetic will help them to see that the sensation of numbness, what it feels like, but also that they will recover from it. And that's really important for children to understand that yes, it feels strange, but that strange feeling will pass and it will go back to normal. So it's really important to introduce local anesthetic in that way. And it usually makes the anesthetic administration much quicker and easier and less fuss. And the parents are usually surprised that their child has had a local anesthetic and hasn't actually batted an eyelid. They're absolutely fine with it. So we're going to move on to a tailored approach to treatment, because now we've got all of these things, all this information. How do we tailor our treatment for this patient? Well, in the initial appointment, when I see patients, I make sure I get a thorough past dental history. This gives me an indication of how much they value dental health. It gives me an indication of how much they will cooperate based on how much treatment they've had. I'm sure as pediatric dentists, you all know this. Again, their brushing habits and whether that or not that will impact their values. I need to know their snacking habits. What are they drinking? This all helps me to understand their socioeconomic status and also how much motivation they have towards treatment, because there's no point in you trying to do heroics for a tooth and do lots of appointments and restorations when the parents aren't interested. They just want the tooth to be taken out and they don't want the headache of coming back and forth. So this is all this information collecting is important when you're treatment planning. And when you're doing your clinical examination, I always offer two choices. If they're very nervous, I ask them to sit in the dental chair or on their parents' lap to begin with. But as we move forward, I would be aiming for them to be on the dental chair, obviously. And so I use a Polaroid camera to get them on the chair to say to them, we're just going to take a photo. And that helps because they take the photo home, they show people, it reinforces that behavior that we want them to repeat the next time that they come in, of sitting on the dental chair. And at the same time, they feel really proud of themselves that they've done that. So again, check their intraoral soft tissues and teeth present. And we also look for habits like thumb sucking, nail biting, tongue thrusting. And we'll also see if they have any caries in their remaining dentition, because it's important that when you're diagnosing MIH, you don't miss everything else as well. So don't focus on the sixes and forget about the rest of the dentition. Child needs to be motivated, the family needs to be motivated, so it's really important that when you're assessing your patient, you see what their motivations are. In the SDSEP guideline, you can see a nice motivational map for motivational interviewing, which is how you can find out what the patient's motivation is. It might be that they want really nice straight teeth, it might be that they want really nice white teeth. So you need to know what their motivation is so that you can help to drive them, and that will help to get them on board for your treatment plan. Another thing that I like to use is Brush DJ. I recommend this to all my patients. It's a nice app, it's free. It reminds teenagers to brush so that the parents don't have to nag them, and it times them for 2 minutes with their favorite music, which is great. Now let's talk about behavior management for these patients. And you can see here on the right with me with my nurse, I like to wear really nice colorful scrubs that make the child feel at ease. And I like this quote. It said, one of the most responsible things you can do as an adult is to become more of a child. So what I would entice you to do is to watch more Disney movies so that you have something to talk to the children about when they come into your clinic. Make sure that you're up to date with all the latest movies. I always say it's like CPD for pediatric dentists. So when I go out at the weekend to watch the latest Disney movie, I put that down as my CPD or CME in the Middle East. What are the challenges? So we have challenges from the patient and we have challenges from the parent. I'm not going to go into detail with this because you're all pediatric dentists. You're all aware of the factors that are involved with managing these patients, and also, you know, dealing with whether they have fear or anxiety is important, because fear is very specific, so you can desensitize them to that, whereas anxiety is very vague and they will just need acclimatizing to the situation for that. And remember, don't mention you know who. If you don't want them to think about pain, do not say pain. If you don't want them to think about something, you don't say it. So if I say to you, don't think about dogs, I know that everybody now who's participating is thinking about dogs. So it's really important to not mention the things that you don't want them to think about. So don't ever say, don't feel scared, because the only thing the child will hear is the word scared, and they will automatically think that they must be scared. In terms of behavioral management techniques, I'm not going to go through these again because, like I said, as pediatric dentists, you're all aware of them. This is a time-lapse video of me taking my daughter, actually, but this is the procedure that I do for new patients. I take a picture of them with their name to start with, to break the ice. I let them choose sunglasses. I take a Polaroid picture. She's got a TV on the roof, on the ceiling, sorry. So she's looking up at that TV screen. I have lots of different pictures of cartoon characters, of myself out with my children, lots of different things, of dental treatment as well. So she's looking at that TV, and I sing as well at the same time. So you might catch me singing Disney songs to my patients if you walk past my clinic. And it distracts them really well because I know all the words to all the Disney songs, which amazes all of my patients and parents, I think. And I take them for a reward at the end from the treasure chest. So I think that most children, when you make it fun, they will enjoy coming. And make sure that if you're losing them in the appointment, try and take a step back. So don't force them to do the next thing. Maybe just take a step back and go back to something that they were actually able to do. Complete that again to regain control, because you want to end on a positive note with your appointments. And if you are in doubt, you can refer to a specialist if you're not a specialist. If you are a specialist, sometimes just taking a break from treatment, reassessing and giving them a couple of weeks break. Sometimes they can just need to change the clinician. Sometimes you just don't bond with that child and they need a different approach, and there's no shame in passing on a patient to a colleague if you really struggle with them. It could be to your benefit and their benefit as well. And I use inhalation sedation a lot. I love it. I'm sure you're all aware of its effects. It has anxiolytic effect, increases their pain threshold, gives a little bit of amnesia, and they lose sense of time. So it's a very valuable tool when you're treating MIH patients who maybe need extractions at a younger age than expected for their permanent molars, and also for their longer restorative procedures as well. And now we're going to come on to the cases. So I've done it a bit differently today. Last time I had some radiographs. This time we're going to talk about what's next. I'm going to give you some hypothetical patients, and we're going to do a poll of what your treatment plan would be for these patients. So now what? I love this, this meme, this GIF from Finding Nemo, one of my favorite Disney movies. Now what? What do we do now? We've got all this information, we've got all these guidelines, we've got all these restorative options. What do we do with them when the patient actually presents in your chair? So you're going to have to choose from the following list. You're going to choose to do enhanced prevention, which type of sealants, which type of restorations, extractions. Will they be immediately done? Will you wait until the optimal time? Will you delay, for example, for class 2? Will you manage this patient on chair? Will he manage with inhalation sedation? Or is this a child who just will not cope with any treatment and will have to be taken for a general anesthetic? So let's start with a 7-year-old boy. So I want to make sure that you're all paying attention now, because we're going to be voting for what the treatment is that we're going to do for this patient. So this is, the photos are not a case, they are a hypothetical case. So I have inverted that same image. So don't worry, you're not seeing double. So let's say, for example, a 7-year-old boy came to your clinic and his upper right and upper left first permanent molars looked like this. His lower right molar looked fine. It has a slight creamish opacity there on the buccal cusp, but apart from that, nothing else. On the lower left 6, he has a bit of post-eruptive breakdown, very localized to one spot, and a defect there which has become carious. So let's also say that this patient is a class 2 patient. He has class 2 malocclusion. He has no previous dental history and he's anxious. And he has hypersensitivity on all of these 6s. So even this one, which appears to be intact, is still hypersensitive. So what we want to know is, what are we going to do for this patient? I have 4 options. The first option is to extract all the 6s under general anesthetic immediately. So he's 7 years old, he's class 2, he's anxious, he has these hypersensitive teeth. Would you extract all the 6s immediately? Or would you temporize or stabilize all the 6s and then extract the 6s at the optimal time under general anesthetic? Would you temporize and stabilize all the 6s, then extract all the 6s at an optimal time under inhalation sedation? And the last option is to temporize and stabilize all the 6s, then extract the lower 6s at the optimal time under IS or GA, followed by extraction of the upper 6s when commencing orthodontic treatment under IS or GA. So I'm going to open the poll for the treatment plan, and we're going to see if anybody is still awake. We have 792 people here, which is phenomenal. Let's see what everybody would do. Let's see. Lots of votes coming in. Did you all notice my glass? I don't know if you can see it, but it says, here we go. You see it? It says, I'm fluent in Disney lyrics and Friends quotes, because I love Disney and Friends. Quite cute. So we've got lots of votes, lots of people are voting. I think I'll leave it open for just a minute and then we'll see what people think. So back to the pictures here. So can you all see the pictures? This is the child. Upper 6s are cheesy, lower right 6s creamy opacity, lower left has post-eruptive breakdown and some overlying caries. He's a class 2, he has no previous dental history, and he's anxious and his teeth are hypersensitive. Okay, I'm going to end the poll now. More than almost half of you have voted. Let's end the poll and we'll share the results. So you should all be able to see the results right now. 50% of you said that it would be D. I think that I would go for D as well. Now, why would we go for D? We go for D because the teeth, we said he's a class 2. So that space that we will get from extracting those upper 6s, which are poor, which are compromised, and they're not going to have a very good long-term prognosis. If we extract them at a time where the orthodontist can utilize that space, we're giving the gift of space, remember, to our orthodontist, and we're killing 2 birds with 1 stone. And at the same time, but that gives us a 2-phase treatment. Now, the problem with doing a 2-phase treatment is you have to make sure that the patient can tolerate that. So if they were going for, if they wanted to have everything done at once, then no, you would probably have to go for stabilizing the 6s until the optimal time and extracting them all, and then presenting your orthodontist with the option of dealing with what they're given, basically, which is usually what happens, you know, if they're not planned adequately. Now, how would you temporize these 6s? So I said stabilize, temporize these 6s. How would you do that? For the uppers, if they're hypersensitive, in the first instance, we'd go for a GIC fissure sealant, see if that helps. In these kind of cheesy molars, it's quite difficult to get fissure sealant to stick. I have mentioned Icon. Icon is starting, some people are starting to report their use on occlusal surfaces of 6s, so that might be an option. But if you were putting on a GIC resin sealant or putting a composite resin and nothing was helping with the sensitivity, then you would probably put on a stainless steel crown. And with the lower left 3/6 here, again, putting on a stainless steel crown or a restoration in the interim. And for the lower right, you would have to put a sealant. But even that tooth, if it was so hypersensitive that no matter what you stuck on top of it, it was still sensitive, it was still causing bother to that child, then you would possibly consider putting a stainless steel crown on a preformed metal crown. So let's move on to the next case. We have an 11-year-old girl. Now this 11-year-old girl, her upper right 6 is looking quite cheesy, upper left 6 is looking fine, and the lowers are looking fine. They just have a creamy opacity on each. How would you treat this patient if she has a class 1 malocclusion and she has a dental history of restorations? So she does have some experience with having treatment, and the only hypersensitivity she has is on that affected molar, 1/6, and her 7s are erupting and not covered in bone radiographically. So keeping in mind these factors, class 1 malocclusion, past dental history of restorations, hypersensitivity on the 1/6, and the 7s erupting, we're going to have 4 options again. Extract the 1/6 and 2/6 immediately on chair with IS. Temporize or stabilize the 1/6 and extract when commencing orthodontic treatment. You can extract the 1/6 immediately on chair with inhalation sedation or with inhalation sedation. You could extract the 1/6 and 4/6 immediately on chair. So what would you do? Let's open up our polling. So this is our treatment plan for this girl who is 11 years old. Let's go back and have another look at it. So she's 11 years old. It's the 1/6 which appears to have a cheesy molar-like appearance, and she has hypersensitivity on it. She's class 1 and her 7s are erupting. These are the options: to extract 1/6 and 2/6 immediately, temporize, stabilize 1/6 and until you commence orthodontic treatment, extract 1/6 immediately, extract 1/6 and 4/6 under, with on chair, or immediately on chair or under IS. What does everybody think? So lots of votes. I think I'm going to wait for another 10 seconds and then I'll close the voting. Okay, I'm going to end the vote now and I'm going to share the results. Here we go. Most people have voted for B. Okay, let's have a look at B. Let's have a look at B. So B was to temporize and stabilize the 1/6 and extract when commencing orthodontic treatment. Extract 1/6 immediately on chair under IS. Extract, okay. So you chose B. Actually, I would probably choose C, personally. Why? Why would I choose C? Because leaving that tooth there, which is crumbling, cheesy, it might become a surgical extraction later on. So that's something else you need to keep in mind. So although the tooth isn't good looking right now, it could probably look worse. When we're doing class 1 malocclusions, remember we said we don't have to compensate and we don't have to balance the extractions. So we definitely don't need to extract anything else at the moment. So we would just need to extract that tooth. If it's bothering her, why not give the 7 more of a chance of coming into that space? Because at 11 years old and her 7s are already erupting or on the path to eruption, it's probably the best time to extract these teeth. So I would actually go for C, and I could do that on chair or with inhalation sedation, because it is quite a big tooth to have removed for a child. Let's move on to the next case, a 6-year-old girl. So she's just presented, her 6s have just come through. She's quite advanced dental age, and her upper right 6 is looking like this. Her upper left is looking sound. Lower left is looking, is also looking sound. Is post-eruptive breakdown, and the lower right is looking sound. So this is actually something that you're presented with quite often in the clinic, is that they are contralateral teeth. So one at the top on the right, one at the bottom on the left. So it's usually the opposite sides, just to make life more difficult. So I've made it more difficult for this case. So a class 2 malocclusion, and she has no dental history. She hasn't had any restorations or anything. She's quite anxious because of that, I guess, and because of her age. And she has hypersensitivity on the 1/6 and 3/6. So the 2 affected teeth are hypersensitive. In addition, she's anxious and she has a class 2 malocclusion. So let's see what the options are for this patient. You could extract all 6s immediately under GA or IS. You could temporize or stabilize the affected 6s and then extract 3/6 at optimal time under GA IS. Then extract 1/6 and 2/6 in line with orthodontic treatment plan under GA or IS. You could temporize or stabilize the affected 6s, then extract 1/6 and 3/6 at the optimal time under GA or IS. Or you could temporize and stabilize the affected 6s, then extract 1/6, 2/6, and 3/6 at optimal time under GA or IS. So I'm going to go back to the pictures for you and look at this case and think, she's a class 2, what would I extract and why? Okay, so what teeth would you extract and when would you extract them? That's the question. So let's open the polling for this and see what you all think. Here we go, launch poll. Everybody can start voting now. So you can extract all the 6s immediately. You can temporize the affected 6s, extract the 3/6 at the optimal time under GA or IS, extract the 1/6 and 2/6 in line with the orthodontic treatment plan under GA or IS. You can temporize or stabilize the affected 6s and extract all of them at the optimal time, or you can temporize, stabilize the affected 6s and extract the 1/6 and 3/6 and 2/6 at the optimal time. Let's see, this is a difficult one. I made it difficult on purpose so that you can see, because sometimes, most of the time, this is what you get in the clinic in real life. You don't get the straightforward cases, and that's why many people don't feel confident in treating cases of MIH when it comes to extractions. So we've got lots of votes. I think we'll give it 5 more seconds. Yeah. Okay, here we go. We're going to end the poll. Most people have gone for B, followed by C, D, and A. So let's have a look at those. So B, lots of people have chosen B. I think I would choose B as well, because the 3/6 is the most affected by timing. You would need to extract the 2/6 to compensate and balance in this case. So that's why you would need to extract the 1/6 and 2/6. However, if that child then started to have pain, if that child had discomfort. If the plan was to have a general anesthetic and you only want to do one general anesthetic, then you would try and temporize them all and then do D, which is to extract those 3 teeth at the optimal time under GA or IS. So I think lots of factors come into play, and it's very difficult to give a conclusion for this case because initially she's presenting and she's 6 years old, but when you're actually going to carry out this treatment when she's 9 or 10 years old, her situation could be totally different. She could be more confident or she could be less confident in the dental environment. You don't know how she's going to be receptive to treatment at that time, which is really important. And also there's lots of other factors such as the parents' wishes. Some parents do not want their children to have general anesthetics. Others would rather that they had a general anesthetic and had everything done at once. So these are all factors which you need to keep in mind. So there is no definitive right answer, but everything is up for discussion. Now let's look at this 10-year-old boy. And he has, his uppers are both affected and his lowers are minimally affected, just showing creamy opacities, but all of them are hypersensitive. So he has another class 2 malocclusion. He is anxious again. He has hypersensitivity on all of his 6s, and the 7s are showing the first signs of calcification at the bifurcation. So I think this is a bit more straightforward, I hope. So let's look at the options for this one. Extract all 6s immediately under GA or IS. Temporize or stabilize the affected 6s, then extract 1 6 and 2 6 in line with orthodontic treatment plan under GA or IS. Temporize, stabilize affected 6s, then extract all 6s in line with orthodontic treatment plan under GA or IS. And the last one is to extract 1 6 and 2 6 immediately under GA or IS. So let's have a look at the poll for this. Here we go, launch the poll. Let's see what people say. What would you do? Would you extract all of them immediately? Would you stabilize them and extract the uppers only? Would you stabilize them and extract all 4 of them later on with orthodontic treatment? Or would you extract the 1 6 and 2 6 immediately? I see it's close for this one. You're going to be, there's 2 schools of thought here, which is fine because we don't expect everybody to think in the same way. There might be a factor that you've taken into consideration which another person hasn't. So remember that he's a class 2, he's anxious, he has hypersensitivity on all of them, and the 7s are showing the first signs of calcification at the bifurcation. What would you do? I'm going to give it 5 more seconds. Let's see. Okay. The clear winner is B. So most of you voted B. Everybody else voted for D, C, and A in that order. Let's have a look at those options. So B, D, C, A. For B, it said temporize, stabilize the affected 6s, then extract 1 6 and 2 6 in line with orthodontic treatment plan under GAIS. I think that's the option I would choose because although the lower teeth have hypersensitivity, that's something that you should be able to address. So you'll be able to put on sealants, to use remineralization techniques to get that sensitivity under control. Some people have said extract 1 6 and 2 6 immediately under GA or IS. Yes, you could do that, but then you're not giving your orthodontist, your poor orthodontist, you're not giving him the gift of space, him or her. So we want to give the orthodontist the gift of space. Remember, it's class 2. So we try and keep hold of those 1 6 and 2 6 until they can utilize that space. But if they were so symptomatic and they were bothering the child, then yes, you could go for immediately extracting those. And then I think it was A, I think, let's see, who was it? Who was next? Yeah, I think it was B and then D and then C and A. So for C, extract all 6s is a bit radical, especially if he's a class 2. I don't think you want to lose anything in the lower arch. So if you're able to control the sensitivity in the lower arch, then I wouldn't recommend extracting them. So let's move on to our final case, which is a 12-year-old boy, and his upper right is sound, his upper left is cheesy, and lower right has post-eruptive breakdown, and the lower left is sound with just a little creamy opacity. So remember, these are just hypothetical patients that I have put together like a jigsaw for you, just to give you an idea of what could present, okay? So let's say that this patient has a class 3 malocclusion. He has no previous dental history and no hypersensitivity. His 7s are nearing eruption, okay, because he's 12 years old, but he has a pain and abscess on the 2-6, and he has a restoration, previous restoration in that tooth, which has failed. So these are the factors I want you to keep in mind. 12-year-old boy, upper left and lower right are affected, no hypersensitivity, his 7s are coming through, he has pain and abscess on the 2-6 and a failed restoration. So let's see, would you touch this patient before seeking an orthodontic opinion? B, would you extract the 2-6 immediately under GA or IS or on chair and then seek an orthodontic opinion? Would you do an RCT of 2-6 and temporize and stabilize the 4-6 and then seek an orthodontic treatment opinion? And lastly, would you prescribe antibiotics, temporize, stabilize all the 2-6 and 4-6 and then seek an orthodontic opinion? Let's see what you would do. We're going to do another poll. I think, here we go, let's launch this one. Let's see, what would you all do? So it's a class 3, upper left and lower right are affected. The upper left, the 2-6 has an abscess and pain. What would you do for this patient? How many people are still awake? So far we have almost 300 out of the 700 awake, which is not bad. No? If we can get 400 of you awake, I think that's a good score. So we've got 20 more seconds because I'm just going to give you a minute to vote. Now remember that he has pain from this tooth. He's a class 3, so the 2-6 is painful. It had a restoration previously. That restoration has failed. The lower right does have breakdown as well. Let's see what happens. Okay, I'm going to stop the vote now. 5, 4, 3, 2, 1. Let's end the poll. And we're going to share the results. Here we go. So most of you said D, prescribe antibiotics, temporize, and then seek an orthodontic opinion. Then the next answer was very close, A and C, so 24% and 23%. So for C, RCT of the 2-6, temporize and seek an orthodontic opinion. A, don't touch this patient. So lots of you remembered when I said don't touch the patient if it's a class 3. That's correct. But the patient is in pain. So pain supersedes everything. It goes above anything that anybody tells you, because your first, what's in the best interest of the patient is to get them out of pain. So actually all of those options, except for B, are valid options. So I wouldn't have a problem with you prescribing antibiotics, temporizing and stabilizing them, and then seeking an orthodontic opinion. I wouldn't have a problem with you doing an RCT of the 2-6 if you felt that was viable. I wouldn't have a problem with you doing those 2 options. I think those are the 2 good options. And then extraction, if that's what the patient wants, because you might have a patient who just says, this tooth is so painful, I really don't care, I don't want to go through root canal treatment, just take it out and get it out of my mouth. The parents might push you for it. So that's also an option. But I think the ideal would be if you don't want to do anything like proceeding with an RCT for a tooth that might be extracted, if you prescribe some antibiotics, temporize those 2 teeth with some temporary restorations, that's a good option until you get your orthodontic opinion, because remember he's a class 3 and we don't touch those without seeing an orthodontist. Okay? So this brings me to some radiographs showing how favorable space closure can look, so that you can see why we are going for this line of extraction treatment. So if you're going for an extraction, you are stopping the restorative cycle for that patient. Instead of signing them up for a lifetime of restorations, RCTs, crowns, you're actually giving them less teeth in their mouth, but they are all healthy teeth in their mouth. So that's why we go for this kind of treatment planning. If you look at this case, you can see that the 6s were affected by MIH. You can see it happens in the opposite sides, opposite arch. That's what usually happens. These are also affected, but to a lesser degree. And you can see that they've been extracted, and what's happened is the 7 is now drifting into the space, and you can see that the final result is that there is adequate space closure. There is adequate space closure here, very minimal space left here, which orthodontists can deal with quite easily, I think. So if you look there, you can see a slight space in the lower arch on the left side. And what happens if you extract at the wrong time, so when it's already, the 7 has already come through the bone, it's not likely to drift into the space of the 6, and that's what's happened here. And you can see that the patient is left with a lot of residual space there, and also some tipping in the upper arch, which will be difficult to restore, but also difficult to keep clean. And if we look at this last case of favorable space closure, you can see this lower right tooth has a periapical lesion, and they've extracted the 6s, and you can see that you've got quite good space closure in both arches, which means that this child now has occluding teeth, which need minimal orthodontic intervention as they go through their lives. So I'm back to my ducks, back to asking you how you're feeling. I should maybe have put the question, are you still awake? How confident do you feel in diagnosing MIH? I'm going to ask you again at the end of this journey that we've been on together before I give you my bonus. And I think we're doing okay for time as well. Let's have a look and see what how everybody is feeling. And I'm pleased to report that for once it's sunny here in Scotland. So we were able to sit in the garden today and actually have some sun, because we're in lockdown. We can't actually go out anywhere other than our back garden. So we have a very small back garden, which we're very grateful for, that we can get a bit of vitamin D. I'm sure you have lots of vitamin D in Saudi Arabia. Let's have a look. Okay, we share the results. Most people, 50% of you are confident, and 38% are very confident, which is fantastic. So let's see how you are feeling in terms of confidence in treating. So after having my session, how do you feel about treating MIH patients? I hope you would feel a lot more confident in being able to tailor to the patient's needs. Let's have a look. I'm seeing lots of confidence, which is very encouraging. Okay, excellent. I'm going to end the poll quite quickly. More than half of you have voted, so half of you are awake, which is fine. I'm happy with that. It's a long webinar. So let's see, share the results, and you can see that most of you are confident or very confident, a few still unsure. So that if you have any questions, I am going to share my details at the end. If you want to ask any questions, I'm happy to answer them. So let's move on to my bonus slides. This is something that I have prepared especially for you, for the Saudi Paediatric Dentistry Society, and this is something which my husband has developed, and I have helped in its development. It's called AVIOS, which is Almisian Virtual Interceptive Orthodontic Analyzer. And what this is it's a gift to you, firstly, and it's an open access web-based app, and it's developed to assist in screening patients who might require interceptive orthodontic treatment. And the reason why it's going to be so useful for you is because it does have a way of screening patients with the compromised first permanent molars. So if the link is there, and I'll share it with you all. If you go into Orthodontic Academy, you can find it. It's called AVIOS Analyzer. What happens is when you go into the website, it will open up this AVIOS Analyzer, which is free of charge to everybody, by the way. So no financial gain from this. It's just a public service. You sign in, given some of your details to this, the analyzer, and then it will come up with this screen, which will give you a list of things that you need to enter. So you will go into local habits, and you will talk about what local habits that child has, whether they have them or not. It will ask you if they have supernumerary teeth. It will ask you if they have hypodontia. It will ask you if they have any transverse relationship discrepancies. And this is the one that I want you to focus on, which is assess maxillary first permanent molars. So you need to tick all of them. Can you see how they have a green tick? What happens is each time you complete one of these screens in your assessment, it will tick them. Once you've ticked all of them, then you can move on, and it will give you an analysis. So when you're doing assess first permanent molars, first permanent molars, it will ask you, have they erupted normally? Are they delayed? And then if they've erupted normally, it will say, do they have a good prognosis or a poor prognosis? Then it will say, are all the teeth present? If all the teeth are present, do you have a second molar root development at bifurcation level, or is it later than bifurcation level or earlier than bifurcation level? So you just click on the option that you want, and it will move you on to the next question. So I chose for this one, second molar at root development later than bifurcation level. Then you have to say if the patient has pain or infection or no pain or infection. So once you've entered all those details, it will give you a result. And what it will say is, in terms of overjet, depending on what you entered in the details, it will give you advice on how to proceed. And then in terms of the maxillary first permanent molars, it will tell you how to proceed. So it might tell you to consult an orthodontist, or it might tell you to actually extract. So it gives you a nice summary of what to do for this patient. And at the end, you can enter a patient ID, which is not traceable, so just a number that is specific to your patient that you will understand. You can print it off, or you can email it to yourself or to your patient, or to your orthodontist that you're working with. So that is my gift to you, the AVIOS Analyzer, which you are free to use. It's available online, and it's open access, and it's free. Hopefully it will help guide you in triaging your patients for any required interceptive orthodontics. And that's the end of my talk. Thank you very much to everybody. Really privileged that you've joined me today, and please wash your hands. That's just to remind you why we're here, because of the coronavirus. And there's a nice website called Wash Your Lyrics, where you can choose your favorite song. Mine is from Frozen 2, and you can sing along as you wash your hands to your favorite song. These are my references, and this is how you can keep in touch with me. So thank you very much, everyone. And I think that...
Thank you very much, Dr. Libby. That was really amazing.
You're welcome. Thank you.
Thank you so much. Actually, we have a lot of questions. It's actually 70 plus. I'm sure we cannot answer all of these questions. And if you don't mind, I will ask all attendees to contact you if they have any questions that we cannot answer at the moment.
That's fine.
Can I share with you some of the questions, Dr.
Yeah,
Libby?
go for it. Yeah.
Yeah, so...
Can you stop your sharing?
Yeah. Here we go.
Okay, so Before starting to give you the questions about the MIH, I will just make a few announcements. The CME, this lecture is accredited by the Saudi Commission for Health Specialties for 2 credits for all Saudi Society of Pediatric Dentistry members, and you will receive the certificate within 7 to 10 days. And if you can, Dr. Ahmed, share the announcement for next week's webinars.
Thank you very much.
So we have around 14 minutes, hopefully, to answer some of the questions. So lots of questions. I will choose just the questions that were repeated by attendees. Some are asking, how can we differentiate between MIH and amelogenesis imperfecta?
So like I mentioned, there's 2 things that you need to look out for. So sometimes the patient will come with what you think is MIH because it's ticking the boxes for MIH, the incisor involvement and the first permanent molar. But if you look at the palatal surface of the incisors, and you see demarcations on that surface, you see white opacities on the palatal surface, then that could indicate that it's actually amelogenesis imperfecta, because the pattern of demarcation in MIH doesn't usually spread to the palatal surface. So that's one indication. But the definitive thing would be to wait until the rest of the permanent dentition is erupted and to look at the canines to see if they also have similar markings, and the premolars and the second molar, if they also had the markings, then that is more likely to be amelogenesis imperfecta. And of course, you can do genetic testing as well. And family history is also a big indicator in that case. You would ask if anybody else in the family has similar markings on their teeth.
Great, thank you, Dr. Bibi. Another question is about the use of tooth mousse or CBB-ACB. Yes. For mild MIH cases. What do you think of this?
Yeah, that's a really good desensitizing agent, and you can use that as a pre-restorative appointment desensitizer to help with the restoration, like I was talking about before. So you can apply fluoride or you can apply the tooth mousse. I give it to my patients as well, especially if they just have sensitivity from just sensitivity on those teeth and nothing else is wrong with them, and I put a sealant on and they're still sensitive. That is a very good treatment modality to give them tooth mousse as well. Yes.
Yeah, thank you. A few questions about ICON. Yeah. They are asking, what do you think, which is more effective, ICON or microabrasion?
ICON seems to infiltrate into the actual tubules in the tooth, and it makes it stronger. Microabrasion is actually taking away a layer of the enamel. So if the defect is in very superficial, then that can help. But actually, a combination of microabrasion and ICON is probably the best, gives the best outcome, because what you're doing is you're taking away that discoloration from the superficial layer, but then you're infiltrating deep into that lesion, and that's what it gives it a new refractive index, and it reflects the light in a way that it becomes less visible as an opacity. So I would say if you do microabrasion for the superficial layer, and then if you do ICON as the next step, that's actually an ideal treatment now.
Great. So you're suggesting a combination of both?
Yeah, a combination of both, yes.
Great. Another question is about the use of new smile zirconia crowns for permanent molars affected with the MIH. What do you think of this?
Yeah, I mean, if the patient is willing to have, it's all about treatment load. So to put the zirconia crowns on, you have to do preparation for the tooth. If the reason that you're putting on the crown on the tooth is because that tooth is hypersensitive, then it's going to be difficult to do your tooth preparation for the zirconia crown and keep the patient comfortable. So that's why I would tend to go for the stainless steel crown, which doesn't need any anesthetic, you know, that kind of thing. So it comes down to patient wishes and parent wishes, and also their tolerance to treatment. But if you had a patient who would tolerate having the zirconia crown on maybe a tooth with post-eruptive breakdown, that you want to temporize until until orthodontic treatment is going to be needed and they'll have an extraction, then yes, it is a good option to put on a zirconia crown if that's what the patient wants, and if you're able to do that without traumatizing your patient, basically.
Yeah. Another question, actually, a point actually raised by one of the pediatric dentistry consultants. She's saying in all of the cases you presented, she wouldn't do extraction in any of them. And she thinks that what about putting stainless steel crown until the patient is around 18, and then I refer the patient for a permanent crown. I mean, a prosthodontist to perform a permanent crown. So what do you think?
This is where it's a bit different in the UK, because it might be based on the healthcare system or just a different school of thought. So actually having that child have the stainless steel crown on, and then later on in their life they'll need to have that crown replaced and possibly need a root canal treatment. What if they failed the crown? Then they would need to have that extracted in the future, and trying to close a space of a molar in an adult is very difficult. Orthodontists don't like to do it a full molar space closure. It's very difficult to move the molar through the bone, the second molar. And in that case, what's happening is you're signing up the patient for a future treatment burden, where they might need a bridge, they might need an implant. So it's about long-term future planning. But by extracting now an unhealthy tooth and allowing a healthy tooth to take its place. So it's all about treatment planning. It's about selecting the right cases. If you're allowing them to have a healthy dentition that is easier for them to care for and means less intervention in the future, that's kind of the treatment goals in the UK. It is difficult to get your head around, because in dentistry you're kind of taught to save the tooth. But then when you're looking at the overall picture of how much stress and strain, financial and mental and physical, on the children and parents, then you need to weigh that up. If they're invested in keeping that tooth, then absolutely fine, go ahead and do the restorative procedures that you need to do. But this is another option which is also very successful.
So generally, you think the system plays an important role in deciding what to choose?
Of course.
Yeah,
of course.
Another interesting question is about the use of SDF for MIH cases.
Yeah.
Would you use silver diamond chloride?
You can use SDF to stabilize MIH teeth, but they do stain, and so I think if you're unable to get anything else on the tooth, yes, you can put SDF on to stabilize any caries that you have on that tooth, or to remineralize it, but you have to be aware that they do stain. I think there are newer ones which are not staining as much. Personally, I don't have much experience using SDF because we don't use it much in the UK. I think it actually post-COVID, I think that this is something that we will be using more. I think that we'll be moving away from aerosol generating treatments for children, and one of the options is SDF. So I think it's something that will come into play a lot more now in the future era of pediatric dentistry in the UK. I'm not sure about in the Middle East.
Yeah. What do you think is the difference between hypomineralization, hypomaturation, and hypoplasia?
So hypoplasia is just that the actual network of the enamel is not built up, but it can still be mineralized. It will be strong, but it will be abnormal in shape and the surface texture. The hypomineralized is you'll get the right morphology, the right shape, but it's very weak because the minerals have hardened it up, and the maturation is sort of it doesn't really apply to MIH. With MIH you get the hypoplasia or the hypomineralization. In terms of treatment, it would affect treatment, I guess, because hypoplasia, you've got a different morphology of the tooth, whereas with the hypomineralization, it's just a weaker tooth. So you really can't say do X, Y, Z. It's looking at each tooth and deciding what it needs at that time, and it's ever changing, which is why these patients need to be monitored really regularly.
Yeah, great. Thank you very much. A question is about what is your opinion about a broader MIH classification that was proposed by Dr. Al-Ghanem 2018 in her paper, where she included the canines and premolars in the MIH classification?
I'm not very familiar with that paper. I've heard of it, but I don't think that MIH by the name, it refers to molar and incisor hypomineralization. I think that if going forward, if we start to do genetic testing and we can isolate a gene or something which is, you know, very specific to MIH, then we can, going forward, that will just become standard to do that test and to keep an eye on these patients before they, you know, before you even see the signs clinically. But until then, I don't think you can include premolars and canines, because that takes away the definition, the initial definition. And in I would say, all the cases that I see that are MIH, I don't see anything happening in the premolars and canines. So that's why it would probably be a differential diagnosis for something else.
Yeah, I agree. Question is about the evidence regarding the timing, the ideal timing for extracting permanent molars, sixes. What is your opinion on this evidence? How strong it is? I mean, why would we say that this is an ideal timing where the bifurcation are calcifying?
So they've done studies. How robust these studies are is negotiable. Is it ethical to go back and do more studies when most of the studies that have come out have said that this is the ideal time, and we're seeing the results visibly where there is spontaneous space closure? And I don't see the need to go back and do more studies and ethically expose people to the risk of not having that space closure when, I mean, in the UK, we follow the guidelines, and the guidelines are never based on, you know, poor evidence.
Yeah,
if they were, they would say this is based on poor evidence. I think that when it's a guideline from the Royal College, I think it's something that you can rely on to be as robust as possible, as feasible ethically as well.
Yeah, I agree. One more question, and then I think we should close. A question is about why do you think the bulk of MIH cases hyperemic?
So the tubules are just more, they're open more. So the actual pathway to the pulp is open more. And so they're getting more stimulus more regularly. So frequent stimulus of the pulp, because you've got that, the open tubules of the enamel, and that's what's frequently stimulating the pulp. And it's that, you know, repeated stimulus, which is making the pulp really hyperemic, really hypersensitive. So that's the reason why.
Thank you very much. Actually, I don't want to stop. This is really informative and very rich webinar with lots of tips. Thank you very much for accepting our invitation.
Thank you for having me.
We hope to see you again in another event for the Saudi Society of Pediatric Dentistry.
That would be great.
And thank you for all the attendees for joining us in this webinar.
Thank you, everyone. And it was a pleasure. And I look forward to working with you again. Thank you so much.
Thank you. Thank you very much. Thank you.